Hello, I'm Valeria Castro. I'm a stroke neurologist from Perugia. I am here at the second ESOC in Barcelona, this stroke conference of Europe. And I'm lucky to be at the first day with Professor Greg Anderson from the University of Sydney and to speak about the ENCHANTED study.
Thank you for having me here.
The ENCHANTED study is a study about the different doses of TPA, 0.9 compared to 0.6, and the different management of blood pressure in acute stroke, intensive lowering blood pressure compared to standard care, lowering blood pressure in acute stroke. So can you tell me about the study, about what about the method, about the challenges you find performing the study?
Yes, thank you very much. So the ENCHANTED is looking at ways to improve the safety and efficacy of TPA or Actylase in acute ischemic stroke. So we've used what we call a quasi-factorial design to have two treatment arms. So the first treatment arm, which we're presenting today, that part of the trial finished earlier, is to compare 0.6 milligrams per kilogram of Actylase with the standard 0.9 milligrams per kilogram. The other arm continues. We hope to present that data in 3 years' time.
So what were the major challenges you found during the trial? I think it was a long time and you had different countries, Asian countries, European countries. So what was your major, let's say, difficulties?
So, you know, randomised controlled trials are always challenging undertakings with recruitment and quality control, and particularly large-scale clinical trials. And this was active comparison and it had two treatment arms, so there were more complexity to it. We had a sample size target for the dose arm, which was 3,300 patients, and we were able to achieve that sample size just under 4 years, which was remarkable. And it's a great effort to all of the investigators. Demonstrates the passion and the interest in the clinical questions that we had to address in the study. So we recruited the patients from 110 hospitals, 13 countries, and 2/3 of the patients came from Asia, because actually that's where there's the most controversy over the dose. Most regulatory authorities have approved a dose of 0.9 milligrams per kilogram based on the pivotal NINS trial, which was published in 1995. But in Japan, because they were concerned that their population is at high risk of bleeding, they approved a lower dose. So this east-west dose dilemma has led to quite varying dose regimes used within Asia based on the doctor's perceived risk of bleeding in the individual patient and the affordability of the treatment. Many patients, as you know, can't afford the Actylase. So we have got a definite answer that can help guide clinical practice for patients around the world.
And now, can you tell us something about the results? Because we are very curious and we really want to know something about this trial.
Okay. So there were two aims to the dose arm. The first aim was around efficacy, to compare the efficacy. And the design we used, which is quite common for active comparison clinical trials, is a non-inferiority design. This is a little bit complex statistically and a little bit complex to get your head around, but you set a margin of loss of efficacy or non-inferiority, and we set that margin to be 1.14 around the odds ratio of unity. And that was set at about half the effectiveness of standard dose of Actylase against placebo. And the 95% confidence interval around the treatment effect odds ratio must not cross that margin. And we set that treatment effect, the primary efficacy, according to the conventional binary cut point on the modified Rankin scale, which is 0 to 1, which is either full recovery or some symptoms, versus a level of disability or death. And that's what the regulatory authorities have done. And we set that up because we wanted to challenge the regulatory authority approval. So for that primary endpoint, we failed to confirm non-inferiority. The 95% confidence interval crossed the margin. However, our secondary endpoint on safety, which was intracerebral hemorrhage, that was definitely better across all of the measurements we use for intracerebral hemorrhage. The primary measure we use, which is a very stringent measure which has been used by the SITS most registry, which is a large parenchymal hemorrhage with neurological deterioration or death within 36 hours. That was a 50% reduction, and mortality from intracerebral hemorrhage within 7 days, that was a 2/3 reduction. So across all the measures, lower dose was much safer, and that prevention of major bleeding translated into a survival benefit. But if you look at the full spectrum of the modified Rankin scale, which gives you more statistical power and more clinical meaning for clinicians, you get a survival benefit with low dose because you prevent major bleeding.
Yeah, sure.
But the offside of that is you get the survivors surviving with a little bit more disability.
Okay.
But if you compare modified Rankin scale shift analysis across all the range, the difference between the two doses was exactly on unity, and the 95% confidence interval cleared the non-inferiority margin. So for all intensive purposes, with clinical relevance, the two doses were equally effective, but the lower dose is much safer. So if you're managing an individual patient where you're worried about bleeding, or if you're working in an environment where issues of safety and survival are particularly important, lower dose is clearly a much safer treatment and almost equally effective as the full dose.
Did you find differences in ages? For example, more safety in higher ages? Did you perform some analysis on this?
So you would think, and we have this inherent perception, that we have to go a little bit easier on the older patients. But actually we could not find any age relationship in the treatment. Age brings with it comorbidity and other factors, and that's what drives the risks of treatment and the adverse outcome with age. But age per se did not influence the safety or the efficacy of treatment. And the other surprising thing from our study is there was no difference in efficacy by ethnicity.
Interesting.
And we worry, the perception we had was that bleeding in the brain was higher in Asian patients. That's why they wanted the lower dose. We could come up with a lot of plausible hypotheses. More lacuna disease, difference in the lytic system of the body, more genetic sensitivity, but the bleeding rates for standard dose were comparable, the same, between Asians and non-Asians, and the risk reduction, the prevention of major hemorrhage, was comparable between Asians and non-Asians.
Very interesting.
So the results we found in terms of low dose are applicable across major ethnic groups.
This is, and you already mentioned about the possibility to select the dose when you think there is a higher risk bleeding patient. But your future vision about this study results, what would you say to the practicing clinician? How will ENCHANTED change your clinical practice?
ENCHANTED challenges our value system. It's what you value. The trouble with the modified Rankin scale is that you grade all the levels with the same weighting. That means you grade survival with a point the same as no symptoms with a point. But actually survival is very precious. And that to live, but live with a little bit of disability is far better than dying. So if you weigh up value judgments for the individual patients, then clearly low dose is a safer option to go than standard dose because you avoid the harms associated with bleeding. If you come in with a minor deficit and you're unfortunate to have a major bleed from the treatment, that makes you feel very bad. So it's offering choices where, where the clinician or the patients or the context in which they live weighing up survival and dependency. I always think that you can rehab a live patient, but you can't rehab a dead patient.
That's
and what we've found here, that clearly the lower dose is a much safer option, and it doesn't really, for all intensive purposes, compromise the efficacy of the treatment in terms of outcome.
Okay, Thank you very much for
Thank
this
you.
exciting interview.
Thank you.